So, good evening, everyone from India. I'm Dr. Gagandeep Kaur, and I welcome you all to Global Interdisciplinary Summit 2020. So, with the huge success of the event and with the wonderful speakers with us, today we are having one more tremendously awesome speaker, Dr. Florin, with us. So, I welcome you all. And before moving on to the session, I would like to mention to all the participants and the viewers, kindly go into the description box for the links regarding the participation C certificates as well as the speaker's schedule. So with this, I would move on to introduce the speaker of our day, Dr. Florin. Dr. Florin is the president of the European Society of Cosmetic Dentistry and a founding member and corporate director of the Society of Aesthetic Dentistry in Romania, the most important dentistry association in Romania. Doctor is editor-in-chief of Dental Tribune International magazine, Romanian edition, and Today newspaper. Doctor is the author of numerous publications on issues surrounding dentistry, and he is editor and author of the book Immersion in Aesthetic Dentistry, published and distributed by SSER in 10,000 copies. As a recognition of his work, in 2015, Quintessence published the volume Comprehensive Aesthetic Dentistry in English, followed in 2017 by the edition in Chinese. His practice is an aesthetically based one, with an accent on all ceramic and implant restorative procedures and aesthetic dentistry. So, with this, I would like to welcome Dr. Florin with us, and sir, the stage is all yours.
Thank you. Good evening for you, and good morning for me because I'm located in Miami now. So we will start the presentation shortly. Thank you, first of all, for letting me in and inviting me to this important global event. It is a pleasure being here, and in this difficult time, it's a pleasure for me in sharing with you the practical information gathered during the years. Sometimes what we see is not exactly what it is in reality. If we look at this image, what we can see a picture of a tank from the Second World War. But if we start to look in details, we see the pictures of the soldiers who fought in the Second World War. It is the same like in our practice, day-by-day practice. If we are using magnification, for sure we're going to be able to see wonderful things that with normal eye we cannot see. So my recommendation for you is whatever you do is to use a magnification. Personally, I'm using the loops. My colleagues in endodontics in my clinics are using the microscope, or as well you can use a microscope in prosthodontics as well. We have sometimes some difficult cases like this one. I wouldn't call them veneers. I would call them like very thin ceramic layers that we are not able to perform a good dentistry without using the magnification. For sure, we will not be able to make the cementation in a proper way without magnification. As my colleague introduced me, my name is Florin Lazarescu, and I'm based in Bucharest, in Romania normally, where I'm conducting an important clinic with over 50 colleagues working together. We have all specialties. And beside working as a dentist, I'm also taking care of European Society of Cosmetic Dentistry, being president for 4 years already, and also director of Romania Society of Aesthetic Dentistry. We are organizing events all over Europe, and also this year we're going to have an event online starting in May, at the end of May, 21st to 23rd. We're going to speak a little bit later about it. It's a very nice family, the aesthetic family. This is our images from the last year event in St. Petersburg with European Society of Cosmetic Dentistry. And for sure, for those of you who are going on this way of aesthetic dentistry, you'll have only very, very nice results and memories. It was said before, I'm very proud that together with my team, we've been able to edit and to publish a book. It's called Comprehensive Aesthetic Dentistry. The book, it was edited at the beginning in Romanian languages and distributed in over 10,000 copies in Romania. And then the Quintessence got involved and they published it in English. And then it was distributed in China as well. It can guide you through all aesthetic dentistry from the beginning, taking of pictures or making the treatment plan, to the materials used, aesthetic in frontal area, aesthetic in posterior area, cementation, and at the end also very special chapters about orthodontics in aesthetics and soft tissue management in aesthetics. Today's lecture, we're going to cover 5 topics. We are going to speak about aesthetic consideration in treatment planning. Then we are going to move to the ceramic use in aesthetic restoration. We are going to speak about ultra-conservative dentistry. Then we are going to review the luting protocol for all ceramic restoration. And at the end, we're going to have a case in which the patient was supposed to choose between digital or traditional way. But let's talk about the beginnings. And for sure, when we're making a treatment plan, we need to know which is the ideal situation. We know that there is a golden proportion of the central incisor. It's the length versus the height. We know that the length versus the width, the width has to be about 75 to 80% from the length of the central incisor. If we are talking about visibility of the lateral incisor, it has to be about 2/3 from the central incisor, and also the visible part of the canine, again 2/3 from the lateral incisor. The zenith point has to be slightly distal than a vertical through the center of the teeth. And also the contact points have to go upwards from central incisor to lateral and central incisor, and then to the canines. The gingival line should be at the same level on the central incisor and the canine. And then on the lateral incisor, it has to be between 0.5 and 2 millimeters below this line. The studies are showing us that the visibility of the dental papilla, it has a 91% of visibility, even in older patients. And even of patients with a low gingival smile, the visibility of the dental papilla appears in 87% of the cases. So we have to consider very careful the dental papilla in the treatment plan that we are doing. If we are speaking now at the proportion between the bone, soft tissue, and the teeth in a normal dentition or an implant, we can predict the tip of the papilla or the place of the marginal gingival level in both cases. So if we have a tooth-to-tooth situation, we know that the tip of the interdental papilla has to be at the maximum 4.5 millimeters above the alveolar bone. If we have in the interdental papilla, it's in between a tooth and an implant, we can predict the tip of the interdental papilla at the same 4.5 millimeters, because the root of the tooth is maintaining this level. The situation is slightly changed. If we have two adjacent implants, we cannot expect more than 3.5 millimeters above the alveolar bone for the interdental papilla. And this information is important when performing surgeries, because sometimes a normal gingivectomy is performed, but if the alveolar bone is closer than 3 millimeters than the free gingival margin, we have to do a bone surgery as well in order to have predictable results. Also, it's important to know that during the age, we have different situations. We can have square teeth, we can have a low gingival smile, we can have a gummy smile, and also while we are aging, the mobility of the upper lip is going to decrease, and the inferior teeth are going to be visible more and more. So if at the age of 30, we have over 3 millimeters visibility of the upper teeth and only 0.5 millimeters of the inferior ones, as we are reaching 70 years old age, the rapport is totally the other way. We have only 0.5 upper teeth visibility and 3 millimeters visibility of the inferior ones. The Kokic and his team, they made some very interesting studies, and they analyzed the perception of between the lay people and the specialists in different situations. And the results are the following. Regarding the midline deviation, if it's a 4 millimeter, up to a 4 millimeter deviation of the central line, upper and lower, is not visible both by orthodontists, specialists, and lay people. The lay people are able to detect it only if it's over 4 millimeters. If we are talking about the midline angulation, it is visible both by specialists and by lay people at 2 millimeters. The cant of the incisal plane, it's visible by specialists at 1 millimeter, and for the lay people, it takes 3 millimeters to be observed. And the lack of the dental papilla, the opening brachure is visible at 3 millimeters, and it is considered unattractive by lay people and the specialists. Of course, we have a lot of possibilities to correct this. We have the possibility of orthodontic intrusion or extrusion. We have the possibility of crown lengthening, connective tissue graft, botulinum toxin treatment, or a surgical lip reposition. Of course, we have to communicate all these details with the patient, and today we have a lot of options. We have the diagnostic or WhatsApp, or we have direct or indirect mock-up. We have the digital smile design possibility. And of course, we have to use a lot of pictures in communication with the lab and also with the dental patients. We have powerful tools. We can use mirrors, contractors, studio images in order to convince our patient that our treatment it's the best one. When we are discussing about the dental materials, I will divide them in two. If we are having anterior restoration or posterior restorations. All the time when we are considering anterior restorations, we are taking into consideration aesthetic ones. Also, we have to choose between monoliths versus layered. But as a general criteria, I would say that the interior, the choice has to go to the aesthetics. And if we are talking about the posteriors, the choice has to go to the strengths. We have to choose between monolithic and the laminated materials, and we have advantages and disadvantages for each of them. For the monolithic materials, generally less tooth restructuring is required, but it's more difficult to mask the color beneath due to the translucency, and they must be bonded. The laminated materials, they have a more reflective coating and they can mask the discoloration very, very well. And also they can be bonded or conventionally cemented. We have sometimes difficult cases like this one. It has a very, very nasty discoloration. And the materials, and also worn teeth. And in this way, in this case, we had to use a lithium disilicate in order to obtain a very, very aesthetic result, but also long-lasting ones. In some cases, we have to alternate with the materials using normal dentition and implants, and we have to choose our materials the best way to copy the underlying material. In other cases that we have only micro veneers, also we have to choose our material in order to restore very nice, but also to be very, very aesthetic. In complex total rehabilitation cases, like in this case, where we use double veneers, we have to choose also the materials according to the strengths and also to the aesthetics. Now, going into the clinical phase, we have this case. It's a lady which came for us for a dental abrasion, and the upper central incisor, they were not visible when the lip was resting. We analyzed and we decided that orthodontic treatment it's necessary in order to be minimum invasive. When we are making the treatment plan for the aesthetic cases, all the time we have in mind this minimal invasive procedure. So we performed at the beginning for alignment a slightly orthodontic, and this is the image after the orthodontic treatment. And then we went on the conventional way, and we took impressions, we sent them to the lab, we made some wax up, and then with the mock-up, we determined the length of the central incisors. After this, after the technique of Galip-Gurel, we started to prepare through the mock-up in order as well to be the minimum invasive. Here, we see the teeth already prepared, and we see the open bite that we have here. In order not to make a crown, we decided to make double veneering, so in order to cover the whole tooth like this. This is a situation from the lab. We see here the ceramic pieces, the vestibular and the palatal veneers, upper, central and lateral incisor. We had crowns on 14 and 16 only, the rest were veneers. It is in between 0.3 and 0.5, the dental veneer at the end. And this is the final situation after cementation. We see that we've been able to perform a very aesthetic result and very functional, a very functional result. The situation before and after. We know we are talking about minimal invasive, and why it's so important? Because the studies are showing us that the resin enamel bonds are very reliable and durable. The presence of the enamel of the margin of the preparation, it offers us a perfect sealing. And even if we have islands of dentin in the middle, if we have the periphery enamel, the bonds are very, very the bond is very, very good. And why this? Because the tensile and shear stress, it's in between 20 and 25 megapascal. And the shrinkage of the composite resin is in between 16 and 18 megapascal. So the strength for between the cement enamel and the ceramic restoration, it's higher than the shrinkage of the composite resin. This is the situation of the dentin now, which is not a mineral, it's a vital tissue. And also at the dentin level, we know that the smear layer, it extends up to 10 microns in the dentin tubules. It's a weak bond, and this smear layer, it's in direct proportion with the grain size of the burr. So this is why we're recommending at least at the margin of the preparation to have enamel. This is a second case. It's a most complex, more complex case where you have a worn dentition. We can see the pulp through on the central incisor. So in this way, in this situation, we knew that we are not able to touch the teeth almost at all. We decided to treat these teeth to make a total rehabilitation in a central equilibration position. And we started with an anterior guidance. The patient had to wear this in between 6 and 8 weeks. And we're able to see the reaction of the condyles and the TMJ articulation. In some situations, only this anterior or total guidance are necessary because we don't have pathology of the TMJ, but in some situations we have to be very, very careful with the TMJ because this is not the only option. What are the occlusal goals for achieving a long-term stability in total rehabilitation? First of all, you have to have stable contacts on all teeth when the condyles are in an adaptive central position. The anterior guidance has to be in harmony with the envelope of the function. We need immediate disocclusion of the posterior teeth in protrusion. We need immediate disocclusion of the posterior teeth on the non-working side. And if possible, we need them on the working side as well. What we are able to do and to perform if we are moving to the central relation, we can have a vertical dimensional augmentation because of the relaxing of the muscles. We can have minimal invasive preparation, no bigger than 1 millimeter. We need to perform at the marginal preparation, as we talked, to be in the enamel. And also we recommend the using of lithium disilicate for the posterior restorations to increase the strength. And of course, at the end, all restoration will be bonded. Like in the previous case, we performed the shell technique through the waxa. And this is a situation after the preparation. We alternate crowns and veneers. And this is a situation at the end of the treatment after cementation. X-ray before and after the preparation. We are not altering the vitality of the teeth. And sometimes, or in most of the cases, we are not using anesthesia at all. Also, we have a 6-year follow-up image. The results is aesthetic, but more important, it's very, very durable. This is another case, very, very interesting. The patient came in need of orthodontic surgery, prosthodontic treatment, so it was a very, very complex case. We started from this situation. This is the initial situation. We decided together with my team that orthodontic treatment was necessary. So it was performed orthodontic, and this is the situation after orthodontic treatment. my colleague aligned, and most important, we have a gingival level according to the standards that we talked before. The implants were already in the oral cavity, and we started by making again a wax up and then a mock-up, and we started the preparation through the mock-up. We see here an image in before and after the preparation, and we see how minimal invasive we were in order to respect this, this principle that we have to stay in the animal as much as possible. This is a situation after preparation, and you are able here to see the using of different ceramic shapes, like tabletops, crowns on implant, veneers. So different shape, because with the bonding we can play a lot. These are images from the ceramic restoration, and these are the final images after the cementation. We can see the patient that went from the beginning, before orthodontic treatment, after orthodontic treatment, and at the end of the prosthodontic, and we see that it's a huge improvement in her aesthetics. It's a treatment that lasted over 3 years, but at the end I say that the results are very aesthetic, and more important, very functional. If we are talking about the luting protocol, even if it's only one tooth, or we have multiple restorations, like a full mouth rehabilitation, we have to perform all the time the same steps. We're going to see now a cementation of a double veneer on a central incisor. We have to decide if we are using dual cure cements or only cure cements. We know if we have a thickness of over 2 millimeters ceramic restoration, we have to use the dual cure cements. So we are starting with the treatment of the ceramic with of the ceramic surfaces. Also, we have to know how much time we have to use the acid on the ceramic restoration, and this we know that it's accordingly to the surface that we are treating. For example, the feldspathic porcelain, we are using 9% hydrofluoric acid solution for 90 seconds. If it's a lithium disilicate cement, we are using 5% of hydrofluoric acid for 20 seconds. We are using the rubber dam in the case of the cementations. The ceramic, it's then washed, and the studies are showing us that only using distilled water for 4 minutes, it's enough. In cases of double veneering, we are starting with a palatal veneer, and then we are moving to the vestibular one. And in case of total rehabilitation, we are starting with the central incisor, then lateral incisor, and then canine. It is advised to use a glycerin layer on the margin of the preparation in order to protect about marginal staining due to the oxygen inhibition during the polymerization. The excess of the cement From the gingival sulcus, it's done with a fine scalpel. I have to say that cementation, sometimes it takes more time than the preparation itself, because we have to treat individually each tooth and to use a rubber dam on each one. Going now to the cases scenario for aesthetics, for traditional or the digital. My colleagues from Cluj University in Romania, they did a very nice study, and they wanted to see the quality of the scanning devices existing on the market now. And what they discovered that if they are using different scanners with, so from some producers with different machine types, they have a better result than using only one producer. But the general conclusion was that the quality of the scanning and of the milling now, it's very, very accurate, and we can trust these scanners existing now in the machines in performing our day-by-day activity. So we have a case here. The patient came in this situation in the dental office, and we decided to make two sets of veneers, conventional ones and digital ones. We did at the beginning wax up from tooth number 16 to 23rd. And then when the patient came back, we took an impression of the wax up. So this is the conventional way, and we made the mock-up. We started to perform, and we started to make the preparation through the wax up. Again, for having the minimal invasive approach, without any kind of anesthesia. We are trying to stay in the animal as much as possible, at least, as I said, at the margin of the preparations. This is an image with the situation after the preparation. What I want you to see here, that in a normal conventional way, I would make a double veneer, a vestibular and a palatal one. But because we are doing also the digital way, there we are not able to mill two different veneers, and we did this kind of palatal preparation in order to have only one mill veneer. At the beginning, we wanted to do the scanning of the wax up, because the wax up had a very aesthetic result and also a very functional one. And then we wanted to tell the machine to copy exactly the design wax up for the final restorations. When we are taking in consideration which method to use, you have to take in consideration the time that we are spending in the dental office, because it's a time-consuming, the scanning, and then all this modeling that normally is done in the dental laboratory. You have to do it by yourself in the dental office, and then the milling itself also it has to be done by you in the dental office. In our case, we did something wrong, and we are not able to have a very aesthetic result in copying the wax up. Something went wrong with the combination between the wax up and on the final restoration. You are going to see at the end of this video what was the result. So we have to learn by our mistakes. So as I said, the aesthetic result wasn't a favorable one. And then we decided to move on and to scan again and to let the machine to do the design and then to work on the design directly on the CEREC, on the computer. Then again, time that you have to take in consideration. But this time we've been more successful, and we've been able to make a very, very nice design. And then we selected the materials. We used lithium disilicate for the lateral area and Empress in the frontal area. But then we milled. Of course, you can do in this phase any kind of adjustment, contact points, and everything that you want. It can be done in this phase. You know exactly what cement you are using. You know exactly how much space you have to leave for the cement. And now we mill the veneers and also the crowns for the posterior area. Then we send the veneers to the dental laboratory in order to be stained. And I will say that it's mandatory to be stained for having an aesthetic result, especially in the frontal area. So this is a step that we cannot avoid. So even if we want to be totally digital, we have to use a dental laboratory at least at the end of our work in order to have the aesthetic result. This is the final result for the digital way. And this is the conventional way. I forgot to tell you that we are able to have 0.3 millimeters thickness for the digital way. This is the conventional way that we are sending the models to the dental laboratory, and the dental technician is starting to add the wax and to do the shape of the veneers or the crowns. Sometimes the dental technician is playing with the thickness of the veneer in order to have some cutback technique or to add some, let's say, reflection of the light on the vestibular way. So it's making it a little bit thicker, the veneer, 0.5, in order to have some cuts in it to have a better aesthetic result. She's checking the contact points. That it's the same that we are doing on the computer, but only digital. The functional movements. Also, we have in the CEREC we have a virtual articulator, and we can check these movements as well on the virtual articulator. This is a final image with the analog way. And here we are trying both with trying cements. We are trying both results, and we let the patient decide. And this is the situation after the cementation. The patient chose the traditional veneers, but she didn't know which one she was choosing. I think it was very subjective, the choice. So we have an aesthetic result and very functional. If we are talking about differences in between these two systems, I would say that the thickness can vary in both cases in between 0.3 and 0.5 millimeters, which is very, very good. The precision and of the marginal adaptation, as we said, it's very good in both cases. We can have the wax up or mock up or a digital smile design in both ways. We have the normal articulator or the virtual articulator, so there is no difference. I would say a difference it's on the double veneer technique, which is not possible in the complete in-office systems because we cannot mill two pieces of ceramic on the same tooth. We would have before to cement one piece of ceramic and then to scan again, but it's a lot lose of time. If a cutback technique is necessary, we need a printed model and we need to send it to the lab. And also we have to take in consideration the total time that we are using. For sure, the future of the dentistry, it's digital. Of course, we are now more using the traditional. My recommendation for you is to take small steps to start with the posterior areas for some tabletops or some inlay, crowns, overlays, and not to do everything digital from the beginning, but to use at least scanning and if we are having the complete in-office system, to use the milling machine as well. As I told you, we are moving online with our events, and it is my pleasure inviting you at the end of this May to an event organized also globally. It's 21st to 23rd of May. So if you are interested, we have very, very good speakers. You can go online on this website. And with this, my presentation is over for today. I would like to thank you and thank you for your attention. If there are questions, I will be gladly to answer.
Thank you so much, sir, for the wonderful presentation. And along with that, the techniques you shared with us. So they were quite interesting. And moreover, moving on to the questionnaire, we are having one question from Dr. Preeti. Sir, can you please repeat the luting part again?
You want to see the slide again with the luting, or just to say a few words about the luting? I didn't understand the question.
So anyway, if you're comfortable.
Okay, let's go to the looking part then again. And to go slowly here. I will share the screen again.
Okay, sir.
So we are starting with the, and I'm making stops now. Hydrofluoric acid. It's a treatment of the dental of the ceramic, and we have to choose, and we have to decide for how long we are using the hydrofluoric acid, and it's important to know that. I'll make a stop. It's important to know that the feldspathic porcelain has to be treated with hydrofluoric solution of 9% for 90 seconds, or if you are using lithium disilicate, it's a 5% of hydrofluoric solution for 20 seconds. So this is performed by our dental assistant, and so the ceramic is treated by our dental assistant. In the same time, in parallel, we are treating the. In this, here I used a cement from Ivoclar Vivadent. It was a three steps cement. So we had primer as well and bonding. Here you see that we applied the rubber dam, and the tooth was treated with orthophosphoric acid, and we started with the cementation of the palatal first, and then we continue of the vestibular side. What was important that after hydrofluoric acid, we cleaned the solution with in the cleaning bath for 2 minutes, and then after cementation we applied. Also, you can clean with orthophosphoric acid, and then to clean it in the bath, it's also advisable. And then at the end of the cementation, so after the cementation, you have the glycerin layer, and I think it's visible here. Here we apply the glycerin in order to prevent the oxygenation of the marginal areas. Did I answer to the question or?
Yes, sir. Yes, sir. It's quite clear actually. And so one more thing I wanted to ask, the prosthesis which you use, like, do you directly etch them, or you use any sort of any surface treatment other than etching on the prosthesis?
It is sandblasted before when it's coming from the dental laboratory. The ceramic it's sandblasted, or
okay.
Yeah.
And they are being followed by etching.
Yes, correct.
Okay. Okay. So next question we have from Dr. Partha. Sir, what machine do you use to print veneers?
Myself, I'm using the Cerec, and it's a MCXL. It's called the milling machine that I'm using in my clinic. This is in the office. I have also dental laboratory. Then we have Aman Girbach, but for the dental office, I'm using the MCXL. And just I think 2 months ago, and I will share the screen again. It's another slide.
Yes, sure.
Again, I will share the screen. It just came the prime scan. It's called. It's the last. This is the last scanner that I got. The other one that you've seen in the movies, it was the OmniCam. This is a prime scan. It's a newer generation from Cerec. It's faster, and it's. I would say that the software is more impressive than the previous one.
Okay. So, sir, don't you prefer like you follow more the veneer part? You don't prefer using full ceramic crowns or full zirconia crowns?
No, I said that I prefer to touch the tooth as little as possible, and in this way I'm using double veneers if I have to cover the both palatal and vestibular surface of the tooth instead of making a crown.
Okay, so
My preference.
so you are preparing the tooth on both labial side and the palatal side, right?
Yeah, you are preparing, or sometimes, as we've seen the case, I think the second case, I didn't touch the palatal side at all, so it was untouched.
Okay, so means like saving the tooth is much more important.
Exactly.
Okay, so the audience has actually liked your lecture and they have given a lot of regards to you regarding that, and they've quite enjoyed the lecture.
Thank you.
So we don't have more questions. Yes, we have one from Dr. Preeti. Is it zirconia veneer or Emax veneer? The one you use.
Emax veneer. I
Okay.
would say that the bonding it's more reliable on the feldspathic or Emax than the zirconia.
Okay. So I hope all the questions of the participants are being cleared. And it was a beautiful oration with the cases you've shared, and it was quite like interactive, and it was quite interesting. Moreover, and thank you for sharing all the knowledge of the lab procedures itself. So
Thank you.
I would really like to thank. Sir, we have one more question from
Please.
participant. It's from Dr. Edgar. On the case that the patient chose the analog veneers and not the digital, was it the same lab?
The lab, it was the same lab which did the painting of the digital veneers. We use the same technician, but
Okay.
on the digital way, we milled the veneers in the office. We just sent them to the lab to make the staining at the end. This is the only moment that the technician touched the veneers.
Okay. And is there any sort of newer technologies which can actually provide you like shades also? Is there any sort of technology being developed right now?
Can you say it again? If it's a technology of?
I mean, is there any sort of newer technology which can give or provide shades also in the
Yeah.
system itself?
When you choose the blocks of the ceramic, there
Hmm.
are
Shades.
you have shades, you have different transparencies, you have multiple shades in the same ceramic block,
Yes.
but for sure you have to stain it at the end, especially in the frontal area. You cannot rely only in the posterior area. Sometimes you just polish it. There are very nice gums and solutions that you can polish it, and it is very nice. But in the frontal area, you have to stain it at least. Sometimes you can have a small cutback technique if you want to be very, very aesthetic.
Okay, definitely, sir. So I would like to thank you for solving all the queries also and for the beautiful session.
Thank you so much.
So would you like to add some words at the end?
Uh, I would like to say enjoy the evening and hope to see you in a real world soon enough.
Definitely, sir.
Thank you.
So with this, we'll move on to the commencement of procession. And along with that, I would like to tell all the audience that for any sort of details regarding speaker schedules and certificates, kindly move on to the links which are there in the description. So thank you so much, sir.
Bye bye.